everybody again. Morning, evening, good night, whatever it is over there, wherever you are. So thank you for joining in. Today's webinar and topic is case management and material selection. And as usual, as I'm kind of running through this the night before, trying to figure out what to talk about, something always pops up. So first, let me start by saying I have, out of the webinars that are coming up for the rest of the year, we've made 2 or 3 of them, I think 3 of them now, team events. So in May, we're going to have my buddy, Dr. Dane out of Ohio. He'll be with me. I think in August, maybe, I have Dr. Savan, and in September will probably be Dr. Bernadette, or maybe that one was October. I wasn't sure of those dates yet, but I'm really looking forward to the team ones these days. And part of the reason is because of what we're talking about today, as far as case management and material selections. It's not really just on us. And I think that's part of the problems that we face, is that we see things come in and we don't have the ability to didactically work through the scenario and make the changes. So coincidentally, I think it was yesterday or the day before, I received a phone call from an out-of-state doctor, a really great guy and a bright guy. So I don't want to make it sound like he missed his mark here, but it was interesting because this is the picture that came in, the picture that you're looking at all the way over to the left of the screen. And his concern was on the phone was, Peter, I just sent you a few pictures. I want you to look. This is going to be a really challenging case because we're going to need pink. And I thought, okay, well, I get it. But if I'm only looking at that picture, what ability do I have to really manage my way through the cases? So I said, well, can you send me a full face? And sure enough, the full face came in. And I looked at the full face and I'm like, okay. I'm still not sure I have enough info here, because your concern at this moment is about the pink restorative that the patient previously had, obviously because of the loss of the tissue. And I get that, and that's definitely a challenge, but it's kind of a backwards way to look at it, because although I'm pretty sure at the end I'm going to need to do some sort of pink restorative on this, unless the patient has enough bony structure and we could do some tissue grafts, which is a whole different discussion. And for me, it's really about the simplicity. And the simplicity is, before I start to look at the tissue, I need to understand the incisal edge position. And I think I've belated this topic so many times for so many people, but I also feel like we still keep skipping it, right? Even clinically, it gets lost amongst the process. So how can I make a case management or material selection determination without looking through all the aspects of this patient? And obviously, I haven't even started this case yet. But before I started it, and before he started impressioning and sending me all the information, I said to the doctor, you know, the first concern I have is really about the incisal edge position. So let's take a look a little close up and look at what we see when we look at where this incisal edge position is on this patient. Now, by the way, before I get there, one of the photography issues here is that the patient did what they normally do. I always joke and say women have that extra chromosome where as soon as the camera comes out, their head kind of cants a little bit to one side. And this is exactly what she did, right? She canted her head a little bit because that's what she's comfortable doing. And the doctor didn't catch that she was doing that. And now all the information becomes more and more skewed. So the first thing that I want to do is take that photograph and kind of straighten that head out. And let me be really clear in how I say this. I am not straightening it out to the interpupillary line. That is ridiculous. 80 something percent of the interpupillary lines are not level to the horizontal plane. I'm straightening the head out to the natural head position, which I would rather do by making the patient do that and not have to alter it in my computer. But in this particular scenario, that's what I did. I just did a very slight alteration so you can see the difference between picture 2 and picture 3 on the screen. And yes, look at the interpupillary line. It is not straight, so I'm not using that as my reference. The next thing I'm looking at is, where is the incisal edge? And I think most of you probably looking at this photograph are saying to yourself, well, those look a little long. Look at the incisal edge position. It's touching the wet-dry line, right? The vermilion border, and some of the teeth are even past it. So my first thought, before I worry about how much pink she needs, is let's get the incisal edge position right. So called the doctor back quick, and I said, you know, do me a favor. I said, I'm not really comfortable. I don't know if you are, where the incisal edge position is on this patient. I would much rather, before you do anything else, you shorten it a little bit for me, and let's figure out if we can figure that out right now before we start going forward with the case. So sure enough, he looked at it, and I want to make sure you're looking at it clearly, right? This is really where that edge is, and she's on the vermilion border and past it in other areas. Look at the bulbous nip of the lip of the bulbousness of the lip here, right? And then you can also see how much tooth display there is going back. So right off the bat, for me, that's a challenge, and I want to move these up. I'd say at least a millimeter. Although I'm not sure if a millimeter is going to be enough, right? So maybe we're going to need more than that. I have to make a determination. So easily, the doctor went back and he said, okay, yeah, you're right. He said, I see it. Let me shorten them. So he shortened them, brought the patient back out, and took a second picture. And I think you can see right away, just by looking at the second picture, that way better, right? I mean, if I really zoom in here, let me see. I can only do this zoom. Okay, so much better. But is it perfect? I'm not sure. So I said, I'll tell you what, maybe you should shorten up just a little bit more because I still think she's showing a lot more than I'd like to. And while he was doing that, I threw this quickly into a Smile Cloud program, and I started kind of moving the teeth around myself quickly. I'm not great with the program yet. I'm working on it to get better at it. But I mean, I could do this now in 2-3 minutes where I can actually take the teeth and move them around and shorten them and kind of give myself a better idea. So as he was kind of readjusting and taking new pictures, I did that quick in a digital program. He finalized, and I said, you know what? I think that's a much better position for her. And yeah, we're probably still going to need pink, but maybe not the way you think, right? Because now that we have the teeth in a much better plane, it really makes it a lot easier for us. So I can't stress enough that when we're going through these cases and managing, you really got to take that step, make sure we're getting that proper head position and that incisal edge position. And all the time, no matter what the case is, that's really where it starts for me. Similar here with this patient. This is a patient I think I've done, oh God, probably 10 years ago now. Really wonderful lady. She carries herself so well. You can see that her incisal edge position wasn't horrible by any means. It was kind of okay. She had a little bit of a display, which we were comfortable with, but really there was so much more going on to the case, right? So she gave us great information because we already had her working incisal edge position. But what she didn't give us was now how do we look through the case and decide what material to use, when to use it, or where to use it in this particular case. Obviously, there was crown and bridge work that was been done before, and you can see a multitude of wear going on here, both functional and chemical, by the way. So we take a look at that challenge and we do all the things that we normally would do. We're going to retract the patient. We're going to look at the interpupillary lines. We're going to look at the horizontal plane. And again, you can see interpupillary line is nowhere near level of the horizontal head position, which is what she is in right now. So we'll do everything that we normally would do. We'll start a diagnostic wax up. That wax up will go back to the doctor with some reduction matrices, and I'm going to go through this a little bit more, and then also some preparation guides. And these become really kind of critical for us to help communicate the information. Once we've done that in the laboratory, a lot of this is really up to our clinical partner. And what I'm expecting of them is to utilize that information to really make sure that they're giving me back what I need, because I'm only as good as their preparations and their management, and they're going to only be as good as my final casework. So it's kind of a catch-22 that we got to work with each other. You can see the wax up was placed in the mouth after the preparations were done. And we kind of like this display. We lengthened the centrals a little tiny bit, created a little bit more of an arc happening there. Right away, when I looked at the preparations, it started to drive the material selection. And this is where I think it's funny to me because we say material selection, but material selection is really secondary to case management. I have to manage the case first, understand where the incisal edge belongs, where the position of the teeth are going to be, and then I start looking at the options for materials. Now, in this particular case, the patient was periodontally involved. We did want to splint the teeth, which is something that we don't do as much of today as we did years ago, but this was 10 years ago or so. And even at this point today, if I was redoing this case, I probably would be connecting it because she has a little bit of resorption around the root, and we really wanted to kind of create as much strength across the arch as we could. So also because of that, I went metal ceramic for one reason, because I was splitting them. I didn't want a very rigid material like zirconia here. Also because of the connector sizes. Look at the size of the connection that we're going to have look at the finish line of the margins between the 7 and 8, and look at where the incisor ledge is going to finish. So how much connector will I have, and can I have done that in zirconia? Probably could have. But it's a little close, right? Because that metal ceramic, I can get a much better opening. I can make that connector 1.5 to 2 millimeters, where with zirconia, I really need to stay in that 3 to 4 millimeter range. So for that reason, we decided to go old school, metal ceramics. We did all the normal things that we did, shade evaluation, of course, and then finalize the case. Whenever I do metal ceramics or zirconia, I'm usually doing ceramic margins. Most of you guys are aware of that because of the fluorescence and the material choices that I have there for aesthetics. And you'll notice what I'm talking about with my connector here, right? Look at the connector on the centrals when I'm all done. By the time I open up a little bit of an embrasure space here for the high papillas and a little bit of embrasure space on the inside of the ledge, look at my contact. Could I have gotten away with it in zirconia? Maybe, but I don't think it was really worth the effort to try. So for me, I'm picking that material based on what I'm seeing intraoral to finalize that case. So we'll finalize her. There she is before and after. And again, this is, I think, at least about a 10-year-old case now, maybe even more. But you can see the final smile, final restorations. And I don't know about you guys, but I feel like metal ceramics, zirconia ceramics, lithium disilicate ceramics, all of them have the same challenges aesthetically. Some of them have higher values and lower values. Some of them have different parameters with the substructures. But in the end, I'm trying to zone in to which one is the best one or the best option for us as we're working through the case itself. I've also showed over a period of time about all the options that we really have. So like I said to start, as I'm looking through my cases and trying to manage, I'm not really thinking about that material until after I've decided where the teeth belong. But I think you know that this is pretty much all the materials that we work with today: feldspathic, zirconia, lithium disilicate, metal ceramics. And as I've said before, I find that most of our profession today is working way more in this area where it's micro-layered, pressed, and monolithics. Nothing wrong with that. I do them too. My only concern is the aesthetic challenges that we face, especially in the anterior, and when and where we're choosing it. What I try to do is really choose the right material for the case and not let the manufacturers or the marketing make that material choice for us, which is I'll throw the clinicians under the bus and say, I think sometimes for the clinicians listening, you're choosing those materials way too often on all the advertising that's coming down your way. We're really, and I just wrote an editorial about this, I think it'll be in the June issue, or the May issue, that actually talks about that a little bit, where it's a team effort, right? It's really about speaking with our clinical partners and kind of understanding what material is going to work best in that environment and choosing it right for the case. The other challenges with some of these cases when I'm in implant world, I could tell you that I'm still going more metal ceramic than zirconias. I'm doing zirconia a lot of times, but in certain cases when you see, let's be honest, this is a mess, right? There's so many challenges here. When you're seeing these kind of really tough cases, I could tell you that my brain is already jumping to a metal ceramic solution because I'm thinking about all the things that I was thinking about before, not only about the incisal edge position, but then the connector sizes, the thinness or thickness of the frames and the support over the implants, the flexural rates. So all those things start going through my mind right in the beginning. And I didn't have the resolve to say 100% this would be metal ceramics when I was working through the diagnosis, but my brain was kind of canting in that direction a little bit just because of looking at these kind of cases and what I'm trying to achieve in the final result. So we went through the entire diagnostic, implant placement, and I have a hand in that, which is great with most of the clinicians that I work with. So we could dictate where we'd like those implants to be, especially when it's a pink and white involved case. I find this really a challenge with a lot of the doctors that I speak to, the newer doctors that come our way, is they're placing implants without really considering the final result. And the final result meaning, where is that incisal edge position? Where will the pink be if we need it? Are we in the FP 1, 2, 3 world? And those are the real two determinations of where those implants should be, besides for the amount of bone that we have. Obviously, that bone will dictate how many implants and where we can place them, but I also want to have some control on that in managing the white and pink. So I already know this is going to be a white and pink case. The less amount of implants in the anterior four, the better for me. I get it that sometimes I can't control that because of the bone, but if I can, then I would really rather not have implants in areas like this because it just makes it more challenging, right? It's because now I have to manage the pink and white and the hygiene of this case, and that makes it much more challenging. So yes, in the end, I did wind up going metal ceramic on this case. And again, look at my connector sizes. They're fairly thick, which is great, but also they're very thin from a buccolingual point of view. So yes, I would have had the height that I needed for zirconia. I wouldn't have necessarily had the thickness I needed for it. And the other real reason is then where the screw access channels were, I would have had a very thin tube of titanium and have a large amount of zirconia hanging off that, which I didn't really like either. So chose to go old school metal ceramics. It was a white and pink case. Obviously, I tried to spend as much time working on the hygiene aspect of that as I can, and it wound up being a full arch case actually. And because of the metal ceramic option, now you see that I was able to actually screw this in as a direct screw. I could have done it with zirconia, by the way, but again, think of the concept of it. I took out the slides that show the tie cylinders that would have been cut at certain angles, and then I would have had to have just basically one wall of titanium supporting a 5 pound process of acrylic of a zirconia, which really doesn't make sense for me. So metal ceramics is still a good way to go for a lot of these cases. It doesn't have to be, but it's a way that I go a lot of the times for these cases. Okay, when they're not implant drawn, the other challenge that I think we're facing in managing these cases is really more about the preparations. And I can tell you that there's a good amount of cases I see where I'm calling the doctors back and saying, we missed this third plane a little bit. Maybe your second plane is a little too bulky. We need to address that now. So I can't emphasize enough that communication piece between the clinical and laboratory is probably the number one that is being missed today. Our job is to help them, and their job is to help us, right? So we want to really go to look at those three planes and understand each of those planes and the value and the challenges that those planes present for us. Right, the cervical plane where we're going to have usually the thinnest amount of reduction, and also we usually need the most amount of light transmission and coloration, right? The second plane where we're looking for that brighter, whiter type of a look there, and if it's bulky already, then we have a substructure or material that might cause a challenge for us. And that third plane where the incisal edge really turns in, where we need translucencies and other aspects of nature. So it's really important that we kind of go through this with our clinical partners as often as we can. Obviously, they've learned this in school and they prep teeth every day. But just like us, I mean, we do things over and over again. And instead of them becoming second nature, sometimes we forget. I had an issue recently where I was adding to a refractory veneer and I completely started using a different material and forgot that how low of a fusing temperature I used to go to, right? So every once in a while, it's like the things that we think we know, they leave our brain and we forget. So we got to stay focused on these things and focus on the angulations of the prep designs. And I try to communicate with that with my doctors as much as I can, because if they do that, then it becomes easier for me to pick and choose the material selections that I need, create some fluorescence and opacities and translucencies for the restoration. This is a slide that I've showed a bunch of times, and it's kind of one of my favorite slides because I kind of came to it by accident. I kind of came to it because I was really just kind of going through the planes and the zones that we worked for, and it didn't really hit me until I started putting them on the screen how important that these planes really are. So let's look at a natural tooth and the three planes. And let's take a look at this angle or this plane is usually where we have the most amount of chroma in the restoration. So think about that from a section that this angle gives you the most light absorption, hopefully some fluorescence, and where we want translucency to allow light back into the tooth and into the tissue. The second zone is the zone that's the furthest out of the arch, and that's the zone where we get the most brightness and most value and most reflection. So we do need reduction there, but we also need to be able to bounce the light off that area to create that final value and that final brightness. And then that third zone, or that angle of that preparation, is where we get the most kind of translucency or age-related type effects. And those become real critical for us because that's where, between the second and third zones, I'd say is where I see the least amount of reduction being done. And those are the areas that usually need the most. Not saying the gingival doesn't. We're managing the gingival much more with um, slight chamfers and shoulders, right? So we have a little bit of ability to get some light transmission in there. But these areas become the most challenging for us in the preparation design as I work through the cases. And kind of one of my new favorite slides that I made a little while ago is I want you to think of the teeth from a ceramic perspective or a restorative perspective all the time. What do I mean by that? What does the dentin actually do? Well, the dentin actually provides for us the color, the opacity, it gives us the lobes and the mamelons and some of the fluorescence. And all that really comes from the dentin. So if you're not taking away enough of the dentin or you're not creating enough space for the ceramist, then you're not giving them the ability to utilize this option that comes from nature itself. The second part is the enamel. And the enamel really has more to do with the final shape of the restoration. It really is more about those final line angles and those heights of contour. It gives us the surface topography. It filters the dentin. It gives us some light filtering options into the dentin. It's where we get opalescence and it's where we create the halo of the tooth. So those two things have to be thought through in the preparation design. What am I taking away? Am I taking away the color and opacity, or am I taking away the shape and the topography? And depending on which one of those options, that really depends on the material selection that we use, how we create light and the interaction between the light, and do we need more reduction or less reduction for a substructure. In veneer world, it's easy, right? Because we're leaving the dentin most of the time, and we're really just working in this area. But once we get past veneer, past 5/10 of a millimeter, now we're into the dentin. We have to start thinking about all these other options and how do I create space and room to do those. So again, this is a really old case, probably another 8-10-year-old case. I'm sorry, I go back and look at old cases every now and then because I feel like, boy, I showed that case not that long ago. I don't want to show that one again. So I'm always looking for a newer case or an older case to kind of put into a lecture. But interesting case, patient had a diastema to start with. We're going to try to treat this case as minimally invasive as possible. Now you could see based on this patient's smile that we're not going to be shortening the incisal edge to this position. So this vermilion border is not going to affect us, although he is much further behind. This is really a lip dynamic or tooth position issue that we're not going to be able to change without orthodontic surgery, and that's not going to happen. So his teeth are going to pretty much stay where they are. And one of the first things that I want to do is, as I'm working up the wax up of the case, is start with some reduction guides. So after I've completed the wax up, I want to utilize that wax up for the doctor to have some reduction guides. And I can't stress enough the challenges of the doctors using these guides and us maybe making more of them for them. We really recommend that they have at least 2 or 3 reduction guides. This is a facial reduction guide. So just make a putty matrix over it. We can come back and clean that up, and then we'll actually take a little cut through that guide and use it just to have an idea of the facial position of the teeth, and just snaps over the posterior teeth and gives them a good reduction guide. You can also cut it in layers, so you can actually have the incisal edge, the mid-third, and the gingival. And this is a guide that really works well, so the doctor can place it in the mouth and then peel it back and evaluate if they've reduced enough in there. They work very nicely. The other types of guides are, that's the facial guide again still. The other types of guides could be a lingual matrix or a lingual incisal, but this one really works well, right? Because you have the ability to show all the positionings and kind of move them away a little at a time. So very critical that you provide that for your clinical partners. After that, we're going to make a matrix for the provisionalization. We use a hard outer shell for that matrix, and then a clear PVS material for the inner aspects of that. So it's basically a 2-part matrix system, and that matrix system allows us to have a little bit of both, where we get the rigidity from the outside and the softness and the accuracy for topography and surface on the inside with a good impression material. Now, it's interesting because this is a case that I actually showed in a hands-on course for doctors in New Jersey that I did with Dr. Bernadette and Dr. Bob about a few months ago. And it was so, again, hindsight is so easy, right? So it's easy to pick on things that we missed back in the day, but also I like to look at them as more learning aspects and things that we can learn from them. So this particular case, you can see the patient already had a diastema. We did have preparation guides back then. It wasn't like we weren't using them. But interesting enough, when I go back and look at the photos of the preparation guides, you should notice a few things right away. For one, let's look at the diastema. So if we're closing the diastema, I'd say one of the challenges that we probably missed here back all those years ago was these margins should have been dropped more. That margin should have been slightly more subgingival, so I had the ability to close this black triangle or close that embrasure earlier on. Having it here means that I had to take my ceramic and push it over this area quickly and pinch off the papilla, which is not really the way I want to do it. I'd rather bring it out from subgingival and work it to the point of the contact where I want it to be. Second challenge is look at the finish line of the preparation of where the tooth is supposed to finish, but where the actual finish line of the preparation is. So realistically, we say we want to be minimally invasive dentists. I get it. Problem is, as a minimally invasive dentist here, you made it much more difficult for the ceramist because without breaking that contact means you couldn't roll this back to where it needed to be. So I can then create a new contact and put the tooth positions where they need to be. I think it's even more evident on this side. Yeah, so if you look at the 10, look at how the finish line of the 10 actually is past the finish line of where I want the tooth to be. So it makes it much more challenging managing the materials without understanding the relationship of where the teeth are and when we should or shouldn't break contact. And I get it. We're in the world where everybody wants to be, I don't prep teeth anymore. Well, it sounds great in theory, but it doesn't always work because that little bit of saving, I don't know, 0.6 of a millimeter of enamel there may have compromised the aesthetics on the entire case. So at this point, we're looking at cases where, of course, we want to stay minimally invasive and save tooth structure, but my bottom line for doing that has changed, and it's changed in several ways. One, age of the patient. If you're 30 as compared to 80, I'm thinking differently about preparations. I'm also doing it based on the final aesthetics, tooth position with orthodontics. Can we shift teeth before we start working on the case? If we can, that'll save us, right? We could have easily orthodontically moved these two teeth 0.5 millimeter over, and that would have fixed all the challenges we had. Then we wouldn't have had to deal with this contact because it would have been open already, and we wouldn't have minded taking away that tooth, but we would have saved more tooth structure on the centrals, right? So it's kind of like a crazy circle that we go down because we're so intent on saving something that we're forgetting all the common sense that goes into it. So let's take a little more look at this because it becomes so more obvious. By the way, the case came okay. But my point is, looking back is where we're learning, right? The mistakes that we've made and how we can improve them for the next time. So this is where we wanted all those teeth to be. And if you kind of look at exactly what my point was, very difficult for me to create the embrasure space on the laterals, very difficult for me to create the emergence profile here because of where the papilla is and where the emergence profiles of the preps were. And then how do I finish this area here and still create embrasure space, right? So it was really challenging to get to all those things and get the heights of contours and the line angles where we really need them to be. So we did it. I tried to build up my ceramics to the best of my ability following that plane. And obviously I used the guide to help kind of get the ceramics where I needed them to be and start closing off, creating my layers and my mamelons and all the things I would normally do in my ceramic buildup, and then finalize the case with surface topography and all the things that we normally would do. So by the way, I think this might have been one of my first VM9 cases, if I'm not mistaken. It was somewhere a good 10 years ago, this case. So I think it was one of my first VM9 cases that I used for veneers, by the way. And it's a great looking case. I don't like many of my cases from years ago, but this one really worked nice and it worked well in the patient's face and gave us all the things that we wanted to achieve in that, even with some of the challenges that we faced as we looked through the case. So really important that we kind of work through those details, and we kind of look at each of the cases, and we try to make an understanding of what we can improve on for the future. And that's why I look back on these cases. I try to look back on them and think, where are we? What did we do right? What did we do wrong? And what can we make better? I do get it in this world. Everybody wants to be minimally invasive. It doesn't mean I don't do a lot of full coverage cases on zirconias and lithium silicates and all the other materials. This is actually a full coverage zirconia case. And then, yeah, sometimes we're really minimally invasive. We're not even prepping teeth at all. And whatever the scenario is, we're still trying to save teeth. And we do that with orthodontics. So when we started a case like this, without going through the whole case, the first train of thought that the doctor and I went to was, how do we work around this? And the only option we came up with was we have to move those teeth, because otherwise the preparations here are going to be so aggressive, and this patient's only 20 something years old, it seems silly. So we have to draw our line. And the doctor, I think, drew a great line with the patient that I will treat you, but you need orthodontics. And the type of orthodontics is a discussion we can have. It's really about speed and efficiency. So if you want it done quick, we're going to put you in brackets. If you want to take a little longer, maybe it's going to be DCA trays or something that's going to maybe take the movements a little bit longer. But the point of it is we're not going to go forward with the case until we realize that we can get the teeth somewhat out of our way and utilize what we're seeing without having to destroy all the teeth. Now, would I have changed my opinion if the patient was 75 or 80? I might have. Maybe I don't want them in orthodontics for a year or two. Maybe I want to be a little more aggressive on the prep and just go straight to getting the teeth where we want them to be. So you do have to play that balancing card a little bit as we're working through it. Some of the importances of the prep design that I think we also miss out on is the form and retention resistance that still exists today. Obviously, the cements that we use are so much better than ever, and the bonding abilities are great, but I'm not looking at them just for resistance. I'm also looking at them for path of insertion from tooth to tooth and for restorative support, meaning that I need space for substructure and I need space for ceramic. So yes, when we're in full coverage, we're still kind of going usually more normal 1.2 to 1.5 restorations, and there are cases where we don't. And when we don't, we're probably going more micro-layered or monolithic materials, which have different challenges to them in the small, thin spaces that we face. So either one of them works. It's really just a matter of getting our parallelism of our preps together, cleanliness of the margin and the cord pack, and managing that tissue. And then we always recommend to all the clinical partners that before they impression their cases, that they microabrade. I can't tell you how many cases I see that come in where we see a lot of moisture on the preparations themselves. And the reason we're seeing that is twofold. One, maybe clinically the doctors are not managing the moisture as well as they should, and that works against us in both old school impressions and digital impressions. It's still the same challenge. If there's a lot of saliva in the mouth, if the patient's not dry and the environment is not dry, then the scanners and the impression materials are picking that up. The best way to avoid that is microabrasion. So microabrasion, a fancy word of saying sandblasting, we're roughening the surfaces of these teeth, and I want the microabrasion to be somewhat aggressive in the sense that the more abrasion you place on the tooth, the more you break the surface tension of the tooth, and the more you break the surface tension of the tooth, the harder it is for moisture to stay on the tooth. And let's be clear, if you're still in old school impression materials, which I like for certain cases, those old school impression materials most of them are hydrophobic, meaning they don't like water. So if the teeth is very smooth and shiny and it has a high quality of a surface tension to it, because our clinical partners use an older burr or didn't microabrade, then that surface wants to reject the impression material or even the light from the scanner. So we really want to have a more roughened surface to manage through that preparation design. The other little challenge that I do see with some of the minimally invasive, especially in the posterior, obviously in the anterior it's aesthetics, in the posterior it's function. And what I see here is that because we're trying to minimally invade our preparations, you're leaving what I call danger spots. And these danger spots are the areas where no matter what material you are, monolithic or layered, this is a spot where the doctor did a ton of reduction here on the axial wall, but not enough reduction in the third plane. And yes, molars have three planes too, just like the anterior teeth do. So I want to always kind of help the doctors realize that when you're prepping your posterior teeth, you're looking at the occlusal table more than you're looking at the angulation of the tooth. It's more about moving the angulation to fit the need of the occlusal table, not the other way around. So what I see a lot of times is kind of more of this, where that occlusal table is not reduced enough, or that third plane is not rolled in enough. And that presents a big challenge for us, especially in the monolithic world. So for those of you who are only digital impressions and only doing monolithic molars, and that's very common today, this is the area where you're going to find fracture almost all the time. Because first of all, without going too far into science, this is the problem with my lectures. Every slide I put in makes me want to put 30 more slides in. So it's so hard to, I think I was at 140 slides about an hour ago, and I got this one down to 110. And I still have more that I should have taken out. But here's why I'm saying that. If you understand the nature of lithium disilicate, lithium disilicate is a log-like structure. So if you look at it under an SEM scope, the structure is like long log looking like structures. Well, if I'm flowing my lithium disilicate into my mold, look at how those logs would have to flow around this peak and then into this area and then thin here. So I get thin, thick, thin. And what you get is not an even distribution of the molecular structure of the material, which means now you have a weak spot. And then if your prep is slightly sharp, the patient bites down. I can't tell you how many times the doctor has called me and said, I didn't cement it and they bit too quick to check it and they cracked it in half. Well, yeah, because you didn't reduce those corners enough. You didn't roll that third plane back enough. And then the functional concern was the problem that we have. So I can't stress enough that those are the areas that we have to work through. And then the last part of the preparation design is also managing from the bone level. Right? So there are obviously different types of bones that we're dealing with, and we have to understand where the marginal placement should be, both anterior and posterior, in these rehabilitations. So for me, what I'm looking about is I want to save as much of the periodontum as I can, but I also have to base it on where the bone really is. There are three basic types of bone heights: high crest, low crest, and medium crest, and each one of them presents different challenges for us. So when we have a very low crest of bone, that the doctor has the ability to prep a little bit deeper. The problem with that is really then what type of tissue do we have? Because if the bone is that high and you start to prep too deep and break the epithelial attachment, you could get recession. So if it's a normal medium level bone, obviously we're trying to stay in the free gingiva and that sulcus. And then if it's a high crest of bone, it becomes even more challenging, because we have less space to prep down. And usually when you have high crests of bone, we usually have a very thin phenotype, very thin biotype of tissue, and that becomes a different challenge for us to look through. So all of these aspects kind of keep coming back to the same process of how do we prep our teeth, when do we stay minimally invasive, when do we not. In the minimally invasive world, some of the challenges I see where we're not breaking contacts are, one, the marginal finish line based on the phenotype of tissue that we have, and then two, creating enough of an elbow. I think Castellano calls it dog leg, which I kind of like, a golfing term. But it's that elbow preparation, right, where I can kind of start to create this. The other thing that I would warn you about, let me go back one slide, I'm sorry. The other thing that I would warn you about is on these little angles or elbows or dog legs, the more depth you can get, the better. The problem is the tooth starts to become 360 round here, right? It turns in again. So the further back you go, kind of the more reduction you need, not to create an undercut as you get towards the lingual, unless, like I said to you in that other case, we drop the margin more. So you can drop the margin placement more and change the emergence profile, and then that allows you a little more freedom there. The other thing that I would tell you is on these minimally invasive cases, if you look at the finish line on the incisal edge, I really want my finish line to be a true shoulder preparation, and the reduction is 1 to 2 millimeters depending on the type of tooth and the aesthetic parameters we're looking for. The minute that I see cases where you need more reduction, right? Where we're looking at a prep finish line of here, which should be normal. Or maybe you say, well, there's wear here, there's friction here, there's some chemical erosion. I should drop it. Or the tooth was prepped before. You're the second person doing a veneer. And now you want to drop this marginal line here. Once you get into that area, I don't look at these as minimally invasive preps anymore. You now need to stop thinking that this is okay and bring the prep all the way down, because you're not doing us a service because of the functional attribute of where now we're bringing our lower incisal edge in the envelope. So for me, I really want to keep these minimally invasive preps in the incisal edge with a true shoulder type preparation. The minute I have to start wrapping over, I'm thinking most likely we've made a mistake and you're dictating material, because I'm no longer do I want to stay in feldspathic. I kind of have to go to lithium disilicate at that point because of the functional concern. And then my lithium disilicate becomes a wear factor for the lower incisal edge position. Feldspathic does too, but not as aggressive as the lithium disilicate. So think about those things as we're going through our preparation designs and how we communicate with our clinical partners. I've showed this case a billion times. This is a great example of that. We weren't doing restorative dentistry. This is kind of a more of a patchwork. Patient just really wanted to close that diastema and he didn't like the space. So this is that elbow prep though that I was just talking about that Savan documented so nice for us, where it comes around that finish line here. When he gets into that area, he's really changing that angulation to make sure that we get the depth in there and then bringing that burr all the way down. And I can't emphasize enough the importance of that preparation when you're not breaking contacts. On the contra side of that, notice that on this case, on this tooth, it's actually a non-prep case. He did prep it, and he only prepped it just to give me a smooth surface and do exactly what I said before, be able to drop that margin slightly subgingival to change the emergence. So is it really a prep tooth? No, he just smoothed out this area a little bit so I can have path of insertion for my final restoration. The whole rest of the tooth is not really prepped. Here he dropped the same thing. Look at the depth of the shoulder here. Why? So I can change the emergence profile. So this is where the old school looking at our cases is great for us, because then we could see the little mistakes we made and incorporate them now into the more current cases for us. And you want to think of this leaving that contact. You want to get under the contact, subgingival, and back to make that happen. Okay, same all the time. And yes, if you're going to change the angle or stop dropping the ceramics back here, then I don't think this should be veneer anymore. I think you should really keep this in our brain about where our incisal finish line is all the time. So I don't want to spend too much more time on the contacts here. Just to finalize, in this case, I think most of you know, I showed this case before. This was minimally invasive. Digital too, by the way. There was a digital transfer done, and I did digital veneers on these. This is the, I call it the Evolve material. VITA calls it Mark II. I like Evolve better. I think really all this is feldspathic ceramics. And I can't tell you how many times I show these and people are like, wow, these are so cool. I even had a technician in Oregon call me recently and said, I just did a few and how beautiful they came. Really a great option for one, feldspathic veneers, which I hope you're charging more for, and two, still getting a nice looking material in a very minimalist space without all the work of refractory dyes and all the other things that we have to do. So if you ever ask for that material, always ask for Evolve, because it drives Jim and the staff crazy over there, and I like that. But just so you know, it's really called Mark II. I just changed the name myself for the fun of it. Here's our final results. So two little digitally made veneers, right? I mean, I milled these at a few tenths of a millimeter. I didn't even add any ceramic to them, stained and glazed, and they work really nicely. I don't always do them that way. Obviously, sometimes I'm going feldspathic on a kind of case like this. I think Dr. Savan and I will show the details of this case in our webinar together. It'll be kind of fun because she's made a great video afterwards, and we went through the whole story about what she wanted to do. But the only point I'm making is there were times for digital, there are times for feldspathic. Either one of those for me with these veneers and minimally invasive veneers, I still would rather a physical impression because of the reasons that I just showed you with those contacts. The digital scanner doesn't read that as well. So I still prefer digital, and also for the surface typography. So I get to see the surface typography on the teeth next to it, where you won't get that in the final restorations. Okay, so uh, all the options work, whether it's feldspathic, whether it's old school metal ceramics, whether it's zirconia or lithium silicates. I'm going to finish up with a case here that I don't think I've shown in a really long time. I was actually trying to pull another case out for today that I was going to go through maybe one of the next webinars. That was a very involved case with implants and bone growth over a period of 10, 20 years, and really interesting case, but I didn't have the finals available to me yet. So I found this case, which was kind of a similar world, no implants replaced. This is Andrea. I used to show this case so often, so I didn't even look at it. I just threw it in here, and I can probably wing through it pretty well because I think I showed that case over and over again for about 5 straight years. Andrea is a ballerina. Those of you might know my daughter is a dancer too, so this was one of her teachers years ago. And Andrea was really a great lady, is a great lady. She came up to me after a show one day and said, I heard you're a dentist. I said, no, I'm not. I'm a technician, but I play one on TV sometimes. And I would really like to fix my teeth. And I'm like, all right, well, let's take a look at what you have. So that's Andrea, and there's my daughter, and I still get teary-eyed every time I show that photograph. Andrea had lots of issues going on. She had a root canal done years before. She had some serious periodontal issues. You could see the root resorption happening here, how short it is. You can see the bone loss happening here. And by the way, the picture I'm going to show you is going to make it look worse than it is, in the sense that Andrea, I can't stress enough, she was petite, hygienic and clean, and all the things that you would expect. But when you look at her teeth like this, you think, oh my God, what is she doing to her teeth? Well, this isn't her doing it. This is her body reaction, right? The tissue resorption, the black, the triangles, the dark stump shade, and then also the calcium that's being formed. She's had cleanings, but it just kind of comes back quicker on her because of the periodontal issues. So I could tell you that we debated on this case for so long. And remember, this case is probably, if not 10, maybe 12 years old at this point, might even be older. Um, Back then, our train of thought was so different. Should we pull these teeth and place implants? And we kind of hedged on that for a long time. We knew back then, we thought that if she has periodontal disease, we pull the tooth and you place an implant there, that we don't have periodontal disease anymore. Well, that's not true. Now we have periodontal implantitis. So placing the implant wouldn't have helped her. She still would have had the biological challenges that she had. Also, the functional concern of where the teeth were hitting on the lower, the loss of tissue, the dark preps. I mean, so many things we can go on here with, right? So we went through our risk assessment all those years ago. The periodontal was high risk for us. The biomechanics was okay. The functional wasn't that bad, but we thought we had to modify it. And really where we were concerned was the dental facial, right? How we create aesthetics in this patient. Look at her other teeth. I mean, like, beautiful molars and bites, not a dot of wear. I mean, almost perfection, right? Except for a filling or two. So really the challenge was in the aesthetic world and managing what we saw. So in the end, after a few long debates and arguments, Dr. Mike and I decided that we were going to try to save the teeth. And we did. So we decided to change who she was. And what I mean by that, who she was, from a person who had black triangles and bell-shaped teeth, to a person who's now going to have square teeth, because that's the only way we're going to be able to close that black triangle. And we're also attempting to maybe do some internal bleaching. But back then, I remember calling Pascal Magnier and saying, she has a root canal there. I'd like to internal bleach, but she had periodontal disease and it's not active at this moment. But what do you think we should do? And his words were, don't do it. We don't have the research or the studies to prove that we can internal bleach with periodontal disease and have it reactivated. So we didn't want to take that chance, so we didn't do it, which changes my material concepts, right? How am I going to manage through the materials and mask that black triangle? So we put our wax up in the mouth. You can see Dr. Mike adjusting it. Again, hindsight is great because we would never want a doctor to make that adjustment in the chair like that. Today, the patient sits up or stands up, and we're actually adjusting that position with them standing and looking at us at a horizontal plane, not laying back in the dental chair like that. Mike went in there and started prepping out for the teeth, and you can see what's going on here already. I got one tooth that's, I always joke and say this is A16. It's all the way down the end of the A scale that most people don't even have anymore, right? And we made her a little provisional shell, and we'll put that in the patient's mouth and put that in. But you can see what I'm dealing with here. But interestingly enough, without restorative there, do you notice how it's kind of like the tissue doesn't look so dark anymore? It's not so bad. So obviously Mike did a little extra reduction there for me, so I had a little bit more room to work with. Cord pack is critical. I can't emphasize enough about managing the tissue in the cord pack. Something I see a lot in the younger generation of dentists that are missing today, where I don't think it's their fault. I think it's the schooling systems today are so jump the gun on every little thing and scanning and doing this that they're really missing out on the key elements of axial wall angulation, prep design, tissue management, margin placements, and cord pack and tissue management. Because all those things are still just as critical in digital world. Matter of fact, they're more critical in digital world. So if you're not good at an analog impression, you're not going to be good at a digital impression. It just can't be. Digital is not fixing it for you. It's the opposite. So you can see where we are. Patient's provisionalized. You can see we're actually getting a nice little bounce back there on that papilla all those years ago. Yeah, the coloration is still a little dark there. We're going to also try to get a little more papilla adapted there. I treated this case as a complete refractory case. And the reason I did that, again, 10, 12 years ago, is because I had the most control of the refractory materials. And I actually built up my refractory substructure first to mask, to make it more opacified, and to get it to look like the adjacent tooth. I kind of tried to simplify the case the best I could. At that point, then I could just treat this as a pretty simple 6-unit veneer case, which is what I did. I want to make sure that I'm managing the biological width, that my marginal finish line and my contact are really close together, because I know we're not going to develop that papilla back. So normally my contact is about 1 millimeter from the marginal finish line. On a case like this, I'm actually going to push that down and maybe go a 0.5 millimeter. I want to really manage the fact that the patient's not going to develop much papilla back because of the bone loss that's around it. So if you take a look, that means my contact is going much further up. I really want to get that contact up there because she's not going to develop much more papilla than we already have right then and there. So I'll finalize the restoration. Everything was a veneer. You can see how thin all the other veneers are, right? Because you see the yellow dye spacer coming through. Yet on this one, you don't see that this is a full coverage. You don't see it because I was able to use my ceramic materials to mask the dark prep shade. And that was really kind of the goal on that. Here's Andrea's final smile. I think from that position, everything looks really nice. And then lastly, there it is close up in the mouth. And I think we did a pretty good job there. And when I saw this case, I thought, wow, I got to give her a call and get her to come in for her 10, 12-year final and get some final pictures for her today. So I'm going to do that. But in the end, that worked out. I think these pictures hang in my model and die room in the back, actually, if I'm not mistaken. And there is her final restoration. So they've lasted, as far as I know, I'm going to knock on wood, for the last 10 to 15 years. I don't know how long it's been. I am curious to see where they are today. I'd like to take a look. But there's our final. And we do still have a little discoloration here, but we did able to close off some of those tissue areas. And there's her final restorations. So great case, Dr. Mike, who currently moved away from the area, but is semi-retired upstate now, if you're watching. I hope I hit all the key points there when we're talking about managing through our cases and looking at restorative material. I didn't dive heavily into the restorative materials because I think it was more about understanding the position of the teeth, the understanding of what we're looking for, and then working through the material. So for me, the material is kind of the open end until I finalize my way through the case and understand what's best for me. And I think I'm almost out of time. All right, so I'll stop here and say thank you. And Jim, I thought I was going to be short, but I wound up being a little long as usual.
No problem at all. It was good information as always. So I think you hit pretty much everything we expected to. Let me go ahead and show my screen here, and we'll finish up on my side. Just so that everyone knows that's asking CE, we're going to go ahead and get that to you as soon as we process everything. The webinar was recorded. And so again, visit us on the VITA North America YouTube channel, in which you'll find this webinar plus a lot of other webinars that Peter's been doing over the years. And believe me, there's a vast amount of information that is on the webinar that Peter's done, different topics, different materials. It's really great to have these as an archive, basically a library. So if you're looking for something specific, you can look it up, and no doubt Peter has probably did a webinar on it. With that said, if you need to get a hold of one of the reps or local here inside the help desk, there's the information, as you can see. And then we do have plenty of more webinars to go. And remind me, Peter, where did we put your team webinar?
I know
Did
the
we?
first one in May, that's with Dr. Dane. I think the second one we didn't put in yet, but I think I was planning it hopefully, I think in July or August with Dr. Savan, and then hopefully a third one maybe in September or October with Dr. Bernadette. So I'm hoping to add about, just maybe change the topics and bring a team member in for a few of them this year.
Great, and we did that last year, and I think it worked really well. You guys did a tremendous job going over the clinical laboratory aspects, and I encourage everyone to join us on those webinars, those team webinars, for communication and so forth. And Peter was gracious enough to provide you with his information on how to get in touch with him. If you do, go ahead and get in touch with him, but just a reminder, Peter's tremendously busy and travels and does lots of lectures. So if he doesn't get back to you quickly, it's okay. He just hasn't gotten to it. He's got some money to make, basically. So make sure you remind you of that. And I'm going to go over a few questions here. And I will, let me see if I can make my.
I have Social sitting next to me, and I'm looking at her notes, and she wrote down, "I talk way too fast."
Let's see here. So questions that we've got. So again, before we leave, if you do have some questions, throw them in, but I'll start with some of the questions that have already been thrown at you. The incisal edge. Is there an average length for the centrals that you try to start off with and then back off on that, or?
There used to be, and then something called Botox and Restylane came into effect. So any information we had on incisal edge position has really changed. And you could thank cosmetics for that, and abuse of Instagram, people telling us where the incisal should be because the lips are now twice the size that they used to be. We've gotten away from using rest position and incisal edge position in the same sentence. For me, I usually use the cuspid position. And the reason the cuspid position is important, because even with Restylane and Botox and lip augmentations, usually this area here on the lip is not as affected. So we'd rather use a cuspid zero position, meaning that we barely see the cuspid in a rest or smiling position. And then that kind of fills into where the incisal edge should be.
The incisal edge of the centrals pretty close to the incisal edge of the cuspids, and the laterals a half a millimeter or around their reduction. Yeah. Okay.
That's dependent on the individual aesthetics, right? The higher laterals, the shorter laterals. But I guess the point from that question to be clear on is the concept of showing 1, 2, 3 millimeters of incisal display on the 8 and 9 is out the window, right? Because that's gone because of the lip augmentation. So and 90% of people have some sort of or maybe not that high, but 70% have some sort of thing happening there where it's changing what that number used to be. So the reference would be the cuspids, zero display, and then the cuspid peak or the circulation coming back to the 8 and 9 is a better way to look at it.
And very patient specific as well. So. A couple of questions about you showed some pictures early on. You have the white stick with the gingiva ball. Was that just a acrylic? It looked like it
Oh,
was a tab, a pink acrylic
yeah.
tab.
Yeah, so I mean, look, we have pink shade tabs and shade guides. VITA makes one, everybody makes one. They're okay. I think part of the challenge with them is they don't really reference well, and pink is way harder to build than white sometimes. So what we've gotten accustomed to doing is we'll usually take pink composites, and you can use Vitas or Annex Dent or whoever you use to make pink composites. The doctors have those chair side, and they'll usually mix one or two of them together, put it on a little stick, and put that in the mouth. So I have that reference. The thickness of the material is more accurate to the amount of ceramic I will use, and then that actually travels back and forth with the case. So I always have that reference point to look at it and compare it to what I'm trying to get to in the ceramic world.
Nice. Okay. Are your preparation, the space for your preparations, is it different between a zirconia or metal framework?
Um, yes and no. So it's more about purpose, I think would be the right answer. So look, can I make a zirconia coping 3/4 of a millimeter? I can. Problem is when I make a zirconia coping 3/4 of a millimeter, especially with most of the directions of the zirconia coping, zirconia materials that we're going in, it's basically transparent at that point, right? So if my prep shade isn't a great prep shade and I have a clear piece of zirconia, then my masking room has changed. So for me in that area, I might want more zirconia and less layering. Or maybe I would switch to a metal ceramic where I can go 2/10 of a millimeter, mask whatever is underneath, and then have more room for layering. I think it's a hard question to answer because it really is case specific. But in general, if it's if it's a minimally invasive case, let's say it's a young patient and we don't want to prep a full millimeter and a half, I get it. Would I go metal ceramic? Of course not, right? I have to go lithium disilicate or zirconia, and then I have to manage the thickness of those materials with how much layering I can do. But in a full coverage preparation, I have the option of going either way. My determination would really be about the prep shade, and the final end shade result would make me determine the substructure.
Okay. And talking about thickness, question was on your opaques to keep it thin for your metal opaque. Do you spray or do you brush or do you use an instrument?
We don't spray. Spray is fabulous, but boy, it's so hard and messy. And we did it years ago. It doesn't work. We're just a brush painted on 2 coats, 3 coats. We always make sure the metal has a very roughened surface. By the way, exactly the same with zirconia. If I'm going to put a liner material on zirconia, I'm making sure the zirconia is very roughened surface. So whatever I put on there kind of really bonds to the material better, and then the layer doesn't have to be as thick.
Zirconia roughness, do you use sandblast or do you use a diamond or? Okay.
Sandblast. No, definitely never diamonds. A diamond is a joke to zirconia, right? No matter how sharp the diamond is, how coarse it is, zirconia just laughs at it and makes the diamond smooth and right, and zirconia just gets shinier and shinier and creates more and more surface tension. So the only way to break the surface tension is truly through microabrasion.
All right. The incisal length, the porcelain, some of those cases look like you had maybe 2 to 3 millimeters of incisal porcelain. But the question is basically incisal length of the porcelain beyond the framework, what do you try to attain?
So, this is more of a functional question than an aesthetic question, right? Because I've showed cases, and I'm sure some of you have seen it who are out there now, and if not, I'll show them again, I'm sure, where a young patient breaks their tooth, and there's a half of a tooth next to a whole tooth, and I've built ceramic 5, 6 millimeters in height, and I have no problem doing that. In an ideal world, we need about 1.5 to 2 millimeters of ceramic to create translucencies and depth and all the things that we need. I don't have a problem if it's more, but all of that is very dependent on your envelope. All of that is very dependent on where that lower incisal edge comes into effect with the incisal edge. And if you're more of a class 3 bite where the edges are very close together, um, you have to be a little bit more concerned with any material kind of sticking out there, especially it's kind of funny to me because when a patient breaks a tooth, um, for some reason we think we could put a material there that will never break and won't do any other damage to the opposing teeth or the dentition. And that doesn't really make sense. Really, when someone breaks a tooth, if it's not through accident or trauma and they broke it through function or wear, then it's really our job to manage the occlusal loads and the forces more than worry about how much material or how little material we use.
And for those of you that are joining us today, uh, Peter actually did an excellent webinar on the envelope of function a while back ago. So that's also on the VITA North America YouTube channel if you want to check that out. Just a couple more questions, unless somebody throws more in. For the prep angles of the axial walls, do you have a difference on that between zirconia or metal framework due to the way it's cemented or quasi bonded?
No, I don't. I think axial wall reduction and angulation is really more about path of insertion from tooth to tooth. Obviously, the more you take off of the incisal edge, the more you have to kind of create that taper and that angle. Usually it's 10 to 12% is normal. There are doctors who I'd say more old school who almost make them so parallel straight that it makes it challenging both in zirconia and metal ceramics for the path of insertion. Now, let's be realistic. With zirconia, it almost backfires on us if those angulations are too parallel. Then what happens is in the axial wall comes down and we angle into that shaft or a shoulder. A lot of times we're blocking those areas out before we're scanning for zirconia or designing it. And then by the time you block that out and go inside and ream a little bit because it's not fitting on the crown, then you get a zirconia coping that's kind of wiggling all around. So I would really rather have a very slight taper on all preparations, and it allows us to not block out as much and get a much more passive fit. And again, the slide I showed with the dowel ferrule effect, I hate to say it's almost old school and ridiculous today because I want those dowel and ferrules for path of insertion and for retentive elements, but the generations that we're using today, we're in generation 9, 10, even 11 and 12 on some different types of ionomers and so forth. So the bonding mechanically and chemically today with most of these materials is fabulous. And we're not, years ago, we only cared about that parallel wall because we didn't want the crown to fall off. Today, that's not really the case.
Excellent. All right, and like always, you mentioned refractory material model, doing a refractory case. So, is there any good refractory material on the market?
So I'm currently using Shera. I think there's somebody had asked me this a while ago. I think they're currently setting up some distribution here in the States. I can connect you with a friend of mine who sells it out of Europe. It's the company is Shera. They're the only really, I think Noritake makes one. I haven't used theirs in a while, but the Shera one is really beautiful and it devests so nicely and it's great. The only negative to it is from a repair point of view, it's a little different than I used to go to repair with the old school Orbit vest, but that's not on the market anymore. So the simple answer is Shera, and if you email me, I'll send you information on it.
Fantastic. And like always, Peter, it was a great presentation, a lot of wealth of information, education. Before we go, any last minute comments to those that have joined us?
No, just thank you guys for tuning in. I think we're working on our date for there's a new facility out in Cali, so I'm really looking forward to
Yes.
seeing it. I think we have a tentative window of something in June where I'll be doing our first course there as like a grand opening. So hopefully we can get that date to work and let everybody know that get some people on the West Coast to come visit us and spend a day or two or three, depending on what kind of a course we do with us at the new facility. I'm looking forward to it. So that's one that I hope works out well. Otherwise, I'll see you in, I think I'm in Spain at the end of the month or London first and a few international trips. So hopefully I'll see you guys somewhere or if not on the next webinar.
Yeah, as always, you're a busy, busy guy. And yes, we look forward to the new facility. We will send all that information out to everyone as soon as we have the new facility up and running with Peter's dates for a workshop. And so I want to thank you again, Peter, for doing this, taking time out of your day. And I want to thank everybody that has joined us today. And I'd like to wish everyone a great remaining portion of their day. And we'll see you next time on another VITA North America VITA Academy webinar. Everyone have a great day and afternoon. Oh, hi.
Take care. Thank you.
Thank you. Thank you, everyone. This will end today's webinar.